Hello there, farmers and friends. Mark with Pharmwyze. I'm a board certified emergency medicine pharmacist that makes clinical pharmacotherapy content on the social medias. I often get questions in the comments, and I compile them into a series called the Drugqueryinbox. I'd appreciate if you hit the follow, subscribe, and notification bell as we get into the questions. For the second Drugqueryinbox, we'll be talking about systemic thrombolytic use in recurrent ischemic stroke, chlamydia treatment regimens, hydrophilic versus lipophilic beta blockers, and lastly, we'll close it out with herpes encephalitis. Our first question comes from Pharmacist Girl on X, and it reads, history of ischemic stroke is only within the last year or 3 years, right? This question was in regards to one of my Metagram patient cases, and the theme of the question was to identify the contraindication to thrombolytics. A systolic greater than 185 would be a contraindication to getting alteplase or tenecteplase. You may have been confused by the duration of history of ischemic stroke because there wasn't one place there. But let me propose to you, what would your approach be or thoughts in the setting of a patient who has a recurrent ischemic stroke and has new debilitating symptoms? Let's clarify really quick the contraindication listed per the guidelines, which comes from the 2019 American Heart Association stroke guidelines. Specifically, the American Heart Association mentions use of IV alteplase in patients presenting with acute ischemic stroke who have had a prior ischemic stroke within 3 months may be harmful. It'll be important for us to look into the rationale behind these recommendations. If you're working with stroke patients and thrombolytics, I would highly encourage you to look into the literature behind alteplase in treating acute ischemic strokes. You should come to your own clinical opinion, especially when so many hospitals are transitioning from alteplase to tenecteplase now. We'll save that discussion for a whole nother video. To get more insight on the question today, we'll look into the scientific rationale behind the inclusion and exclusion criteria provided by the American Heart Association scientific statement, which they released in February of 2016. I'm not going to read the whole statement to you, but I'll make sure to summarize and link the article in the description below. But in summary, they listed history of ischemic stroke within the past 3 months as a contraindication because that's what was listed in the original packaging. And the recommendation to exclude these patients was based on trials of thrombolysis in patients with acute MI or heart attacks. And they mentioned specifically that direct information on the presumed higher risk of intracerebral bleeding in patients with acute ischemic stroke treated with IV alteplase with a recent stroke in the past 3 months was largely lacking. Their recommendation is also consistent with other global organizations in regards to making it a contraindication. The American Heart Association does acknowledge that this is an area of further research. It remains unclear how soon after an ischemic stroke we can give thrombolytics for a recurrent stroke. Currently, the guidelines have this listed as a contraindication for the patient population, but it does propose an interesting patient case and discussion if a patient does present with new debilitating symptoms. The next question comes from Hairbender6 on TikTok, and it reads, is one tablet of azithromycin a full course for chlamydia? So technically, a full course of treatment of chlamydia with azithromycin would be 1,000 milligrams by mouth once. So however you end up getting that 1,000 milligrams with azithromycin would be the treatment course. Azithromycin comes in 250 and 500 milligram tablets. It's important to note, though, that the 2021 IDSA STI guidelines changed the preferred regimen for chlamydia from azithromycin to doxycycline 100 milligrams by mouth twice daily for 7 days. Dombrowski and colleagues completed a randomized controlled trial in 2021 where they compared doxycycline and azithromycin for the treatment of rectal chlamydia in men who have sex with men. They included 135 patients, and they would receive either doxycycline or azithromycin. They would also receive a confirmatory rectal swab at 2 and 4 weeks. From their results, doxycycline had a higher incidence of microbiologic cure compared to azithromycin. The treatment duration and dosing frequency of doxycycline may not be appropriate for some patients, especially those with adherence issues. Azithromycin would be an appropriate alternative, but it just might not be as effective as doxycycline. Our third question comes from Christine C748 on TikTok, and she asked, Could you do one on hydrophilic versus lipophilic beta blockers? There's lots of beta blockers available on the market, so I'll just focus on the ones that are commonly seen as oral options. Beta blockers are often considered as cardiovascular agents, but they've been utilized for a wide spectrum of neuropsychiatric disorders as well. These would include tremors, migraines, anxiety, PTSD, OCD. The agent that has the highest usage for these neuropsychiatric disorders would be propranolol. That's because propranolol has the highest lipophilicity compared to the other beta blockers. This allows it to readily cross the blood-brain barrier to exert its therapeutic benefits. Here's a great review article from Cojocariu and colleagues titled Neuropsychiatric Consequences of Lipophilic Beta Blockers. They have a great table where they show the lipophilicity and hydrophilicity of beta blockers commonly seen. As mentioned earlier, propranolol has the highest lipophilicity compared to the other oral options. It's also why it has the most use for a wide spectrum of neuropsychiatric disorders. It can readily cross the blood-brain barrier due to its lipophilicity. In the middle column, you'll have moderate lipophilicity. The common ones we'll see are metoprolol and carvedilol, mostly with cardiovascular diseases like hypertension and heart failure. In the last column, with low lipophilicity, we have atenolol, which isn't commonly seen as much anymore. Nadolol is more seen in patients with liver disease, and sotalol is primarily used as an antiarrhythmic. The last question for today's Drugqueryinbox comes from user Tabika Yi 2.0 on TikTok. What if you have herpes? You can get encephalitis? Herpes simplex can cause a wide spectrum of infections, including mucosal and genital herpes. That same herpes simplex can also cause encephalitis. Globally, it actually accounts for up to 10% of all viral encephalitis cases. Generally, herpes simplex encephalitis can occur with any age group. It's going to be more concerning in patients who have a weakened immune system or those who are immunocompromised. HSV2 is more common in adults, while HSV1 is more prevalent with neonates. Modern medicine has gotten pretty good at detecting viruses alongside herpes simplex via CSF diagnostics. And antivirals such as acyclovir has dramatically reduced mortality from these infections. I appreciate you for dropping by the second Drugqueryinbox. I hope you enjoyed our discussion on the inclusion and exclusion criteria for alteplase, chlamydia treatment regimens, lipophilic and hydrophilic beta blockers, and herpes encephalitis. Make sure to hit the like, follow, and notification bell. And if you haven't yet, check out my clinical pharmacotherapy content on the social medias. If you have any questions, make sure to drop them in the comments below. And as always, I hope you learned something new.